Good afternoon. Before we begin, I would like to let everybody know that this session is being recorded. These recordings will become available on our website post session. We are very excited to have everybody join us for our 11th DENT Echo. We have a wonderful didactic and case presentations lined up for you today. My name is Kato, and I will be assisting facilitating today's session. For those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions begin with a didactic presentation followed by a identified case-based learning and group discussion to foster the knowledge and build individual capacity. Before we carry on, I will ask Carly, our ECHO IT, to share some guidance about your audio connection.
Hi, and thank you for joining us today. Please stay muted unless you are speaking. You can mute or unmute using the *6 on your phone if you call in, or the microphone icon on the bottom left of your screen if you join on a computer. You can also communicate with the chat feature. Please remember that no personal health information is allowed when discussing cases and scenarios. Thank you.
Thank you, Carly. And if you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions icon. You may need to click on More at the bottom right corner of your Zoom screen to find this menu. If you're having trouble accessing the captions, please let Carly or anybody know on the ECHO team. Let's move on to the introductions. Dr. Chala?
Thank you. And I'm Suman Chala from UT Health San Antonio, and thank you all for taking the time out to join us today.
Ms. De La Torre.
Yes, hello, I'm Magda De La Torre. I'm co-director for DENT Echo. We're so happy to see so many names on here we've seen before and some new welcome faces. So continue to look out for our DENT Echo sessions every 2 months. Thank you so much.
Thank you, Dr. Aguilar.
Hi, good afternoon. I'm Rosalia Aguilar with the DENT Echo Hub. We're happy to have you here today. Welcome and looking forward to today's presentation.
And Dr. Robledo.
Hello, everybody. I'm very happy to be here. I hope you guys will enjoy this. A small, or I mean, if we were to talk about all the oral pathology, you'd have me here for days because I love it so much. But I've tried to kind of compact it down to things that you will be seeing more likely in clinical practice, and also to bring awareness to those lesions that are really important and worrisome, which will help with the diagnosis of dysplastic and cancerous lesions in the oral cavity. So if you have any questions, I would prefer if you leave them for the end. And at the end, we'll have a little time for discussion. And also, I'll give you at the end all my information if you want to contact me privately or afterwards, or if you have any other question you need or have, I will be happy to help you out.
Thank you so much, Dr. Robledo. Before moving on to the didactics, I have a few announcements. So to everybody who's joined this session, please enter your name, title, and affiliation into the chat to help us with attendance, and so that we can get to know each other through chat. If you haven't already completed the pre-session questionnaire, you can do this now using the link in the chat. To receive CDE credits, registration is required through the UT Health CDE website. And we will also follow up by email with the instructions for completing the post-session evaluation and attaining your credits post-session. ECHO is an all teach, all learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. We also encourage you to join by video if you can. You are unmuted, so that we can see your faces. And our session today will include a didactic and case presentation from Dr. Robledo on common oral pathology, lesions, and oral cancer. And as a reminder, you can use the chat to raise questions and comments at any point during the session, but we'll wait until the end to answer all the questions. And Dr. Robledo, we're ready. And whenever you're able to share the slides, please begin.
Okay, let's see. Okay, can everybody see the screen? Yes?
Yes.
Okay, so we're going to talk a little bit about the most common oral pathology lesions that you guys will probably encounter in the oral clinic and in your oral practice, in your dental practice, and kind of establish a little bit what could be the differential diagnoses of these lesions. And also, we then are going to end up talking towards the end a little bit about oral cancer, the premalignant lesions, and how to handle or manage those lesions. And then I'll have different cases that we can maybe have a little bit of a participation from our viewers. Everybody who's here, you can either answer or use the chat to answer some of the questions I will make to everybody. So without any further chitter chatter here, we'll start our conversation. So first, I kind of divided them a little bit into categories, and so we're going to start talking about infectious diseases. And one of the infectious diseases we encounter a lot in practice is candidiasis. And candidiasis has several ways it shows up. So one of them is called pseudomembranous candidiasis. And the way these lesions show up, they look almost like velvety, thick, white lesions. They can, you can see them on the tongue like this. You can see them on the buccal mucosa, soft palate. Usually these show up in patients who have a low salivary flow or xerostomia, or patients who are in a lot of medications. They can be older patients. They can be patients who have gone through radiation therapy, and they usually are accompanied by symptoms. So patients will complain that their mouth burns, that it burns when they eat spicy foods, that sometimes they have metallic tastes in their mouth. And one of the ways you can use that helps to give almost like a clinical diagnosis of these lesions is most of the time these lesions, these pseudomembranous plaques, you're going to be able to rub them off with a gauze or with a tongue depressor. These lesions usually rub off, and then they're going to be these kind of fluffy or almost moldy lesions. And in some cases, we are able to take those lesions that we rubbed off, spread them on a glass slide, and do a special stain to confirm the diagnosis of candidiasis. But for the most part, this diagnosis can be done on a clinical basis, and really we don't really need to confirm it histologically. Another type of candidiasis is known as denture stomatitis, and this is that candidiasis that shows up under a denture or in areas in patients that have dentures, either complete dentures or partial dentures, that they don't use them off, they don't clean them often, they don't remove them often, they sleep with them, they wear them all the time, and these patients start developing kind of red lesions, erythematous lesions underneath the denture, or even papillary and hyperplastic lesions. And in these cases, they will also complain about burning, maybe some metallic taste. And in this case, we need to treat not only the soft tissue, treat the patient with antimycotic medication or antifungal medication, but also treat the denture or the partial denture. So either build a new denture, reline the denture, or treat the denture with some of those chemicals out there. I think they sell those effervescent pastilles that you can put the denture in. Make sure to brush it very well. And also that'll help to get that fungus also out of the denture and not promote the growing of the fungal organisms in the denture and continue with the infection, right? Another type of candidiasis is called hyperplastic candidiasis. And this one is a little bit tricky because, as the name says, it's hyperplastic. So we'll see, the way we see it is kind of these white, thickened plaques. So they look like that pseudomembranous candidiasis, but the difference is that these cannot be wiped off. These are thick plaques. If you try to remove them, you will not be able to remove them. And in this case, when they do show up, if they are, for example, in a lateral border of the tongue, or if you see them in the floor of the mouth, or maybe back there in the soft palate, in areas that may be of a little higher risk, those areas that we consider are high risk areas, it's better to get a biopsy, a tissue biopsy of these lesions. Most of the time, these patients with hyperplastic candidiasis are going to be asymptomatic. And so these patients will not complain there's burning or metallic taste or anything like that. And so there's always a portion of it or part of that lesion that you think, well, could this be a lesion that is premalignant, and because it's kind of thickened, it was a good site for Candida to colonize? So this is one of those questions that what came first, the chicken or the egg, right? Did the lesion come and then the Candida came and made it worse, or was the Candida the first promoter of that lesion, and then the tissue just reacted to that Candida and became thick and atypical? So in this, and most of the time, this hyperplastic candidiasis, actually the diagnosis is made based on that biopsy, on those histologic findings from the biopsy. So if these plaques that cannot be rubbed off are in those critical sites, in those risky sites, lateral border of the tongue, floor of the mouth, soft palate, then it's better to go ahead and biopsy them. And we'll talk a little bit more about white plaques in the oral cavity towards the end of the session. But please remember that if you are considering a candidal infection in hyperplastic candidiasis, you really need to do a biopsy to rule out other problems. And then we have angular chylitis, and as everybody knows, angular chylitis is caused by candidal infection, but usually it's in patients who have lost a little bit of their vertical dimension, and that edge or that commissure really has becomes a kind of a nice little moist area for Candida to kind of grow. It becomes a really good environment for Candida to grow. And so patients will show like these maybe ulcerated lesions, red, almost cracked. They don't heal easily. Patients will try to put on chapstick or Vaseline or any kind of ointment because they think it's chapped, right? And it really doesn't heal. So at that point, it's better to use some kind of antifungal cream. There's also an antifungal cream with an antibacterial and a steroid together, all of them together, and that's like magic for these angular chylitis lesions. And one thing I did want to let you know, and I can, after this lecture becomes available for you guys in the website, I will also make available a little cheat sheet of all the prescriptions that may be important for these conditions, okay? So that can also be available for you guys to have it as reference. Okay. And then another type of infectious disease that we really see often, or it's more often to see, is herpes, right? And herpes, usually they show up as lesions on the lip, and as dentists, we don't want to treat our patients when they have an active, you know, a fever blister, right? Or one of those big vesicles, because by the manipulation, we may spread it, and then the patient will have just a bigger lesion, right? And in some situations, if the patient has had already an infection with herpes in their lip or inside their mouth, sometimes the manipulation with to do dental procedures or anything can make it come back, right? Because herpes will be latent. Herpes has an active lesion. It shows up either because the patient goes out in the sun, or they're out at the beach, they forget to put on sunblock, or they're going through some kind of stress, or maybe they have a horrible cold, and all of a sudden that herpes that's latent within the nerves of the patient, then it says, oh, this is a great opportunity to come out and make a lesion. And so the lesion starts, and usually there's a prodromic sign. And when we talk about a prodromic sign, it's a sign that lets the patient know something is going to happen. And usually that's a little burning, a tingling sensation in one specific area. After that tingling sensation, then the patient has a bump. After the bump becomes a vesicle, and then the vesicle ruptures, and within that vesicle are all the viral particles, because the virus infects the epithelial cell and needs the nucleus of that epithelial cell to multiply. And so that liquid with all those virus particles, if it gets spread, then that's what infects the other epithelial cells. And so when herpes happens the first time in children, it can occur anywhere in the oral cavity. So you can see them like you see here, on the lips, on the tongue, on the gum, it's on the gingiva. It's very red. It's very, it burns. The patients complain that it's painful. They can't eat. So that it would be the primary herpetic gingivostomatitis or primary herpetic infection. And then after this happens, then it becomes latent, which means it goes and lives quietly inside of the nerves. And then whatever triggers it makes the herpes come back. So when it does come back, if it comes back on the lips, then it can spread like this. And this is an exaggerated recurrent infection. But if it comes back intraorally inside of the oral cavity, then it's only going to come back on bound down to bone mucosa. So in all that attached mucosa, hard palate, lingual surfaces of the mandible, buccal surfaces of the attached mandible, and all of these attached mucosa, then that's a recurrent herpetic lesions. And usually they start off as small little tiny bumps that turn into vesicles that rupture really quickly, because how long does a vesicle last in the oral cavity? Not that much, because it's easy to rupture. And then those little ulcers, and if you can see here, those little ulcers kind of coalesce to become bigger ulcers. They're very painful. The patient complains it's really painful. And whatever, if they drink, it burns. If they eat, it burns. If they eat something hot, it burns. But then those usually will heal in about 7 days. After maybe even like 5 to 7 days, these will heal. But those patients can have recurrences like almost every month or every other month. And so whenever it becomes really recurrent and they continuously recur again, sometimes it's good to put these patients on like a prophylactic antiviral medication. And this is just an example of an initial herpetic infection, or so the first infection by herpes in a patient who's never had herpes before and is an adult can also develop this kind of exaggerated herpetic gingivostomatitis. And so that can be confused with other stuff, like aphthous ulcerations or something like that. So usually that first herpetic gingivostomatitis can go with like a little bit of a fever, headaches, malaise, which would be the different symptoms a patient can have. Okay. Okay. So now we're going to talk a little bit about some of the mucosal conditions that you see them very often. And this one is obvious, of course. It's erythema migrans or geographic tongue or benign migratory glossitis. It has a lot of names, and we really don't know exactly what it is. Some authors believe that it's kind of a type of psoriasis or psoriatic mucositis but the way we see it on the tongue is that it's like these serpentigenous white and red formations or structures within the tongue. But what's interesting is that sometimes they can be plaque-like with kind of an erythematous border. And sometimes it's just these lines. And we have another example here. Some of these can be very plaque-like. And usually you see it on the dorsum of the tongue or on the ventral surface, more on the lateral borders and ventral surfaces. There's an ectopic migratory glossitis. So sometimes it can crawl onto the mucosa, the buccal mucosa. But most of the time, these patients are asymptomatic. They've known to have it for the longest time. Sometimes they become symptomatic and they'll say that it burns, that it bothers them. And other times, because of the name, you know the name, benign migratory glossitis, it moves around. So today it may look like this, but in 2 weeks it may be different. And so sometimes the patients get a little bit scared and they get a little bit concerned. What's going on? Last week it was white on this side of my tongue, now it's on this side. And so all you have to do is just reassure them that this is a benign thing, that it's very common. A lot of people have it. It's not going to turn into cancer. At some point it may, what happened? I'm sorry. Sorry about that, guys. At some point it may become symptomatic, and when it does become symptomatic, what really works, you could use some kind of steroid cream or some you know what really works is can everybody see it?
Dr. Robledo, I believe that Carly has the slides up now.
Oh, okay. So what really works is that you know that gel, Benadryl gel that you use sometimes for the bug bite? A little bit of Benadryl gel when it feels like burning the geographic tongue, it works perfect. A lot of my patients have said that works good. And the steroid cream that you can use may be a Lidex cream or some kind of a low steroid cream. There's some with Orabase. You can ask them to mix it with Orabase, but it can either be even one of those Cortaid, you know, the over-the-counter ointment, a little bit of an ointment if it's symptomatic. Okay, the next one. Okay, these are very common lesions, and believe it or not, some people, sometimes they don't look this obvious. Sometimes these Fordyce granules, these kind of yellow bumps on the buccal mucosa, they can get together in clusters, and they can be very deceptive. But what Fordyce granules are, and I'm sure everybody's familiar with them, is they are ectopic sebaceous glands. And when we do biopsy them, they look like normal sebaceous glands. So we don't know if they either got stuck there by accident in the development of our anatomy, or they really have some kind of a function with our saliva. Maybe they give it a little bit of an oiliness to our salivary component. But anyway, these are totally benign. They're not going to turn into anything bad. Sometimes they may become a little bit more hyperplastic, and so like I said, you can see them like maybe in bigger clusters, and they can become a little bit more elevated. And so but usually you don't do anything about it. Just let your patients know that these are sebaceous glands, they're normal glands, and there's nothing to do about it. Next. Okay, another type of lesion is called frictional keratosis, and usually these lesions look like white plaques of the buccal mucosa or white plaques of the lateral border of the tongue, and most of the time we find a cause for them, right? Most of the time the patient says, I've been rubbing my buccal mucosa, I've been biting on my buccal mucosa all the time. The patients have a sharp tooth edge, and so that sharp tooth edge rubs on that side. This one here looks a little bit like a callus, and what it is that the patient drinks a lot of coffee, and so it was rubbing against the buccal mucosa, but the patient drinks coffee, and so that keratin plaque kind of stains a little bit brownish, right? So instead of seeing a white plaque like you see here, you see a little bit of a brownish plaque. But so the best thing to do with these is make sure you find the reason for them, right? Make sure you see what's causing them, try to get rid of it. If it's a sharp tooth, smoothen that sharp tooth, and kind of wait and see if it gets better. If after a couple of weeks, no, don't wait more than 2 weeks. If after 2 weeks, this hasn't really gotten better, maybe it's better to take a biopsy just because you want to rule out that it could be something worse, right? Next. Okay, and this is another type of frictional keratosis in a patient who had a tongue habit. So they constantly stick their tongue out, and that action, that chronic action, one after the other, caused this to create this kind of callus of the tongue, which is, it's just an extra growth of keratin, but keratin, when it becomes wet with our saliva, turns white, right? And so it's like, for those of you who are golfers out there, you golf and you get calluses on your hand, right? Every time you wash your hand and make it wet, those calluses look kind of whitish and spongy, right? The same thing is here. These are calluses that because of our saliva turn white. And this is another type of frictional keratosis in a patient who has a denture that's not fits very well and kind of moves around, and so it's causing also this rubbing and this irritation of the mucosa underneath, and it creates that plaque. Next. Okay, another type of white lesion or superficial lesions of the mucosa is lichen planus, and lichen planus is kind of an immune-mediated condition in which the lymphocytes have some attraction to our tissues, and so they are kind of wanting to go to the oral mucosa, and so clinically you're going to see these striated or kind of cobweb lesions, white lesions, most likely on the buccal mucosa, usually bilaterally, and which sometimes can become ulcerated or erosive, right? And it may be painful. So patients with lichen planus are going to have lesions in the oral cavity, sometimes lesions on their skin, which are usually purple papules, most likely in those areas, flexor surfaces, so on the wrists, on the elbows, on the knees, behind the knees, and lesions in their oral cavity. If it is symptomatic, we usually treat it with some kind of steroid or a potent steroid, clobetasol usually, or even Lidex cream. or some kind of a steroid rinse that they rinse and spit. Patients rinse and spit. But additional to lichen planus, next, we have, this is another example of lichen planus you see here. Next, we have lichenoid lesions. And lichenoid lesions are a little different. Next slide, please. Lichenoid lesions are those lesions, and we call them lichenoid because they look like lichen planus, right? They look like those lichenoid lesions. They are striated, but usually these are kind of hypersensitivity reactions. So you can have lichenoid lesions associated with medications, lichenoid lesions associated with dental materials. There's lichenoid lesions associated like with crowns, metals, amalgams, all kinds of things. And sometimes patients, nothing happens to them for the longest time. And then 15 years later, after they had a crown, a metal crown, or a big metal restoration, an amalgam, after all the mastication and all of that kind of a rubbing of the metallic particles, the things change, and then they start creating a sensitivity reaction of the patient, forming these lichenoid lesions. Next, and you can see here, I have an example of this one. Was this patient had these crowns for the longest time, and all of a sudden started to develop these lichenoid lesions around the gingival margin of those crowns. We got rid of them, and they did porcelain crowns, and it was perfect. The patient got better. And this one is associated to that big mercury, to the mercury in that amalgam restoration. This patient had that lichenoid reaction, and he said that it was already painful, and so they got rid of that, and they were able to get rid of that, and then they used a little bit of steroid to make it better. Next. Okay. Another superficial condition is smokeless tobacco keratosis. We see this in patients who use that either wet tobacco or dry tobacco, that chewing tobacco, when they put it there on the tissue for a long time or for some time, they can develop these corrugated white lesions that appear kind of verrucous or velvety, that when you pull the mucosa, they don't disappear. And usually these will develop depending on how long they've been using the tobacco, what kind of tobacco. There's dry tobacco and wet tobacco. Apparently that chewing tobacco that's a little more moist is worse. And there's in all the variety, there's some that have a higher strength than others. So the ones that have a higher nicotine component or tar component, those may be more irritant. How early they started the use of that. So I had a patient when I was living in Nebraska who started when he was 8 years old. He would help his father out in the fields, and his father would put it on, and the 8-year-old kid would use it. Well, he was 24 years old, and we were diagnosing squamous cell carcinoma from something like this. And then another thing that's important is how many hours consistently they use it, right? If a person just uses it for 1 hour and then spits it out and never puts anything back again, well, the possibility of the mucosa to develop these lesions is a lot less than a patient who uses it all day long, right? And at 7 o'clock at night decides to just take it off, and that's it, no? And also, if where they're placing it, if they consistently put it in the same site, well, the irritation is going to be directly on that site every day. If they move it around, then maybe our organism doesn't have the chance to develop a lesion, right? So in these cases, if you get a patient with a smokeless tobacco keratosis or a lesion like this, you need to palpate it, you need to touch it, make sure it's not super thick. Ask your patient, how about if the best thing to do is to quit doing it, right? If you can't quit doing it, how about if you place it on another side and let's see what it looks like in 2 weeks. After 2 weeks, some of it may have regressed, right? After cessation of use, or cessation of placing it in that same site, these lesions may be able to regress. If they don't regress, or if only part of it regress, whatever is left after 2 weeks, that's what needs to be biopsied, just to make sure there's not already a pre-malignant change in that. Can you change to the next slide, please? And here's an example of one. And so it's usually placed on the vestibule, right? That's kind of the cushy place to put your tobacco, or where patients like to put their tobacco. And so not only is it gonna cause this tissue lesion, but some patients will also have caries, a recession of the gums, all these other things. But we are concerned that they don't develop lesions that are going to be irreversible, right? That are going to be pre-malignant, that are already going to be dysplastic. And so maybe ask them to remove it, wait for a couple of weeks, and if there's anything left, then that's what you need to biopsy. And then your pathologist will tell you, well, it doesn't have dysplasia or it does have dysplasia. If it doesn't have dysplasia, it doesn't give them carte blanche to go and do it again, right? You would hope that they learn their lesson and they're a little bit afraid and they won't do it again. But just kind of tell them, maybe this time you didn't have dysplasia, but if you continue to put it on the same site, then it will likely cause a chronic irritation that will likely turn into a squamous carcinoma. I know that sometimes that there's only so much you can do, right? A patient will like to, it's up to the patient, and you can give them all the information and everything you want, but it's up to him to stop using it, right? And you would hope that he would stop using it. But if they don't, at least urge them to change sites, so that irritation is not always in the same site, and that irritation isn't chronic all the time. Next case. And here's another example of and this patient would put it almost in his entirety. So you have these velvety lesions. If they quit using it, it's likely that all of this goes away. So that would be the best thing that happens. Next. Okay, and then there's some ulcerations, and the most likely ulcerations next are going to be traumatic ulcers, right? And you've seen traumatic ulcers all the time. Usually they'll heal within 7 days, 7 to 10 days. Usually they're associated with something, right? The patient says, oh, I had a sandwich in French bread, it scraped my palate, and here I have a lesion. Or I bit my lip, there's your lesion. 2 weeks later, he's done, it's healed, nothing happens. What happens if it doesn't heal? We need to take a biopsy of that lesion. If an ulcer that you thought was caused by some kind of trauma or irritation, and it doesn't heal after 2 weeks, it's better to take a biopsy to make sure there's nothing worse going on. But also, if the patient has if it is a deep-seated ulcer, then just that small biopsy you take will be helpful in helping this heal up, right? It helps this whole ulceration heal. I think there was somebody, what to do in patients that have chronic cheek biting. Sometimes plates, just creating these plates to help them protect those cheeks may help from that. This is another example from a patient with braces. That always happens, so use that paraffin. This is an orthodontic appliance that was causing an ulcer on the tongue, so that's it. And this is an ulcer caused by a burn, a patient that drank hot coffee and burned his tongue with that. So if this doesn't heal after 2 weeks, then there may be something else going on and we need to biopsy it. Next. And another types of ulcers are recurrent aphthous ulcers or recurrent aphthous stomatitis, and they come in 3 types. Next, there's major, minor, and herpetiform. And the most common ones are the minor aphthous ulcers. Usually you get, they're going to be about 1 millimeter in diameter. They can show up like from 2 to 10 at the same time. Usually the name says the recurrent aphthous ulceration. Some patients know exactly when they're going to come out. We really don't know exactly what causes it. There seems to be kind of a genetic component because some patients say their parents had it, or some parents say, well, I used to have that when I was a kid. In a lot of cases, after they go through puberty and get into adulthood, it stops coming back. And some patients have it associated with something. I remember I used to get them a lot with eating Parmesan cheese. So every time, like if you have a delicious Caesar salad with those Parmesan shavings and they're so good, and I'm like, oh, sorry, I'm gonna get after ulceration. A lot of people say strawberries, some dairies, chocolate has been associated with it, but so we usually don't know what causes it. Steroids will be good, and usually what you do is keep a journal with these patients who do tend to have recurrent after ulcerations. We ask them, keep a food journal. What are you doing? What is your emotional state right now? Are you stressed? All of this, and that can help out. Next, in my major abscess ulcers, they're bigger ulcers, deeper ulcers. They occur in less numbers, so usually 1 to 5, and you can see them more on that posterior palate, kind of on those pillars. We see that these can do very good sometimes with tetracycline, using that tetracycline elixir as a rinse. It helps out because some of these major abscess ulcers are associated with an L form of streptococci. So some of them do well with the tetracycline. And next. And then there's another type, which is the herpetiform abscess ulcers. And don't confuse this with a herpes lesion, because remember, recurrent herpes will show up in bound down to bone mucosa. If you have recurrent ulcers that continue to show up in soft tissues, abscess ulcerations will only show in that movable mucosa, so tongue, buccal mucosa, vestibules, even the marginal gingiva, but not in the attached gingiva. Those are going to be likely abscess ulcerations, and they're called herpetiform, which is kind of confusing, but the reason is because they're tiny, less than 1 millimeter in diameter, and you have little tiny clusters or little tiny ulcers together that cluster all together and become bigger ones. So these were probably several together, and then they all coalesced and became a big one. But this is almost like that minor abscess ulcerations, the same thing. Let's look what they're doing. Let's look what they're eating. Let's look if maybe they have a history, and family history, and see. And most of the time, these patients will get better after they go into adulthood or go through puberty. Next. Okay, next. One of the most common tissue masses is a mucocele, which is a pipe problem. They usually occur due to a rupture of those salivary ducts, right? You have a salivary duct, you bit your lip, that saliva, instead of continue to go through the duct, it starts to go into the connective tissue, into the soft tissue. And so the organism, your body tries to kind of wall off that mucus or that saliva that's coming out of the duct, and forms these balloons or these masses, these fluctuant masses. If they are deeper, then you can see them more blue. When they're more superficial, you can see them more clear or transparent. Usually they're removed by surgical excision with the removal of the adjacent minor salivary glands. So you get those little bit of the lobules around it and the duct itself, so that duct doesn't go back. If you were just to cut the top of it, you still have that duct and the salivary glands around it, which continue to produce saliva, and so it recurs, right? So you really have to go a little bit deeper and take those little glands around it to cure it for good. Next. And these are just other examples. This is actually an interesting one, but because this is a fibroma with a little superficial mucocele next to it. Next. This is another mucocele. And this is a different one. This is a lesion on the marginal gingiva or on the gingiva that looks kind of red and yellowish, and so it's red and ulcerated. And it's a reactive lesion caused by a proliferation of granulation tissue, usually due to some kind of local irritation. So something got stuck in there, a popcorn kernel, or a patient of chicken bone, or a big calculus, or something is causing an irritation and makes this big growth or this redundant tissue to grow as a reactive response to this irritation, right? And so that's why they bleed, the patient, it's really not too painful, but if the patient uses floss, it bleeds, and so it can be uncomfortable. Next. And you can have them in different sizes. They can grow to be kind of big ones, and sometimes they can grow pretty fast. So the only way to get rid of them is going to be by removing them completely. So conservative surgical excision. Then we have another type of soft tissue mass, which is a fibroma, and these are also caused by, these are reactive lesions also caused by chronic irritation or chronic trauma, most of the time on the buccal mucosa by a patient biting. And it's just a lot of fibrous connective tissue, almost like a scar, right? In response, a lot of fibrous connective tissue in response to an irritation, and forms this kind of meaty, firm masses, but they're totally formed of fibrous connective tissue. They're not going to go away by itself. They also need to be conservatively excised. Next. And these are just examples. They can occur also in the marginal gingiva. Next. And the epulis fissuratum is also a type of fibroma or a type of reactive lesion due to an ill-fitting denture. So the denture keeps moving and moving and moving. And so that tissue says, I can't take this anymore. And so it starts trying to form more tissue and more tissue and more tissue to kind of wrap around that denture to kind of hold it in place. And so that's an epulis fissuratum. Usually you can see the dentures kind of fit perfectly in the flange of the denture will fit perfectly in that sulcus made with these within the fold of these lesions. And how to get rid of them, you need to surgically excise them, and then you need to either reline the denture or rebuild a new denture, so that way it's not ill-fitting and the patient doesn't have this problem again. Next. Another example, different folds. And sometimes when the patients are not very good about cleaning their dentures, these denture epulis can also be colonized by Candida. Next. Okay, a squamous papilloma is a lesion caused by the human papilloma virus, usually very low virulence, HPV 6 and 11. They're really nice papillary lesions with finger-like projections that are white. Mostly, you see them mostly in kids and young adults. Sometimes they'll have little papillary lesions on their fingers. They lick their fingers and then they get them in the oral cavity, but the infectivity rate is also very low, so it's not that often, right? Next. And usually this is what you see them. And then you can have other kinds which are more flat papillomas, which look more pebbly and kind of rounded, but they're also associated with HPV 6 and 11, which is low infectivity, low virulence. It's not one of the oncogenic HPVs. And these are just examples of those squamous papillomas on the gum and maybe those on the hands. Next. Okay, and some pigmented lesions, and we'll go quickly through these. An amalgam tattoo, everybody knows. You removed an amalgam, you cleaned your burr on the patient's mucosa, and there you left a little piece of amalgam, and so it comes back. You want to look at these cases, you want to see the color of it. They're usually blue to black. You want to make sure that there's some association of a big amalgam or a big crown or something, or the patient used to have an amalgam. You can always take a radiograph, and there you can see it radiographically. It's going to be radiopaque. And if you really don't know what it is, then take a biopsy and we'll let you know next that it was. And this is a nevus. Nevuses are melanocytic lesions. They're benign lesions of melanocytes, and they're rare in the oral cavity. You usually don't have them that often, but they're usually kind of symmetric. They don't. The color is very homogeneous. It doesn't have like a darker color on one side or it's like invasive on one side and rounded on the other. No, they usually look pretty much all the same. And they can be different types. They can be within the mucosa, so intramucosal, junctional, which is the epithelium and the mucosa, or just in the epithelium. Next. And these are just examples. They're usually, like I said, brown lesions. Here's another example on the palate. So, and they usually don't grow. But if you see one of these and all of a sudden it starts growing and it has a different variegated brown color, darker on one side, then it needs to be biopsied. I like to biopsy all the pigmented brown lesions in the oral cavity. It's easy to access, and I recommend for them to be biopsied. Next. And then we have melanotic macules, which are brown, uniform, flat macules. Usually you have them on the lips. If they're present for less than a year, mostly in older people, maybe we should do a biopsy to rule out melanoma. There are conditions like Peutz-Jeghers and Addison syndrome, where you have pigmentations around your oral cavity. And so that's also important to know. If a patient has a lot of freckles, make sure you know if they have any additional syndrome. When they are large and less well-defined lesions, they might represent maybe hormonal changes, or even patients who are taking some kind of medication that may cause some pigmentation. So that is also important to know when you have these types of pigmented lesions. Next. And this is just an example of a person who takes birth control pills that develop these brownish lesions of her lower lip. Next. And this, please don't ever let a pigmented lesion get like this, because this is a nodular melanoma, and you can see here it's already spread elsewhere. So this patient is not going to do very well. So it's very dark, very irregular. It has satellite lesions, as you see here. So please never let something pigmented go to this step. Next. And then you have all kinds of, these are really not pigmented lesions, but they're red lesions or lesions that are due to some kind of trauma. And we'll go through this pretty fast. Next one. And varicosities, next one. And let's talk a little bit about premalignant lesions, because we have 5 minutes and I want. So when we talk about premalignant lesions, we try to say leukoplakia, erythroplakia, and erythroleukoplakia. We kind of have established that these terms are going to be, even though their meaning is leukoplakia is white plaque, erythroplakia is red plaque, erythroleukoplakia is red and white plaque. We have kind of established in the dental community and in the community that these are lesions that we really don't have a specific cause for them, right? That we see them in the oral cavity, but we really don't know what is causing them. So that we are considering that they may have some kind of malignant potential, right? Next. And so these are the kinds of lesions that worry us. A white lesion on the floor of the mouth. How on earth is that happening, right? Is the patient rubbing the floor of the mouth? No. I mean, it's impossible to call this like a frictional keratosis. So this type of lesion, velvety plaque, kind of diffuse, kind of infiltrative, right? You see it's kind of spreading everywhere. This is a lesion that needs to be biopsied, and maybe not only biopsied in one area, but maybe find a thicker area here, maybe another area here, maybe another, maybe in different sites, biopsy it to get the whole grasp of the lesion. Next. Then we have something called the verrucous leukoplakia, where they start turning more thick, kind of papillary or verrucoid, and they're involving areas that this is not normal. Usually this is not caused by an ill-fitting denture. This is not caused by patient biting on it. So this is bizarre, and you need to biopsy this. Here, maybe back here. You see it's also going on to the oral, the buccal mucosa. There may be a little bit on this side. So these are scary lesions or worrisome lesions. Next. Here's another example. Remember, lateral border of the tongue is a high risk site. So something like this that cannot be rubbed off. The patient has had it there. If, for example, he also has an additional risk factor like smoking or drinking, biopsy this lesion. Please don't let it go. Another example, this one is a leukoplakia, but here is a little thicker than here. So maybe, and here looks a little red. So maybe biopsy here and biopsy here. This is a little kind of more homogeneous, but it's also lateral border of the tongue. Next. And then we have erythroplakic lesions, more intense red. Also, you try to blanch them, they won't blanch. The patient says it's been there for a while. Here's another example. Next. Another one, this one was a case where this turned out to be carcinoma in situ. Next. And you have a combination, right? Red and white. There's red, there's white over here, you know? So these are, next. This is another example of a red and white lesion. This was already cancer. And then we talk about oral epithelial dysplasia, right? We're concerned about these lesions being or transforming into squamous cell carcinoma. And for squamous cell carcinoma to occur, it doesn't just happen. It has a progression, right? So it'll start from mild dysplasia all the way to severe dysplasia, carcinoma in situ, and finally cancer. So here's mild dysplasia where the lower third of the epithelial surface is affected or it's atypical, and obviously some keratin production. Next, and you see what looks clinically. Then you have moderate dysplasia, which was that lesion I showed you before, where now that the changes involves at least half of the epithelial surface, and moderate dysplasia is already considered a high-grade dysplasia. Next. And then you have severe dysplasia, where it's almost the entire surface of the epithelium is affected. So it starts becoming proliferative, and now you're concerned that this is going to turn into cancer tomorrow. Next. So a little bit of oral cancer, and you guys can go through this when it becomes available. Next one. Next. The risk factors, you know, all of these are risk factors, and now we have additional HPV-associated oral cancer, right? Next. So we kind of have the two phases of cancer, the HPV positive and then the HPV negative or classic oral carcinoma. Usually this one is associated with smoking and drinking, and this one is in a younger population, a higher socioeconomic status, and associated with oral sex or HPV caused by oral sex. Next. And these, I just brought these because it's impossible to miss these. I mean, if you get lesions like this, you have to biopsy or refer to be biopsied. Next. And then these are examples of conventional oral squamous cell carcinoma. Next. So ultimately, it's important to know that it's HPV because these have a better prognosis. They are treated better. There's a treatment plan for them, and they do a lot better with chemotherapy than the classic squamous cell carcinoma. Next. And then next, we can, and then these are just examples of HPV. Remember, HPV associated is mostly in the oral pharynx. Next. So posterior pillars, tonsils, base of the tongue, posterior pharyngeal wall, and you can see it here. So all of this is considered oropharynx. Soft palate, posterior pillars, tongue, and posterior pharyngeal wall, base of the tongue. Next. So what do you do as a dentist? You have to have a good observation and clinical exam, establish a differential diagnosis, right? Make sure you say, well, is this a frictional keratosis or is it truly a leukoplakia? You need to see if there's a true need for a tissue biopsy. You need to make that decision. If there is a need for a tissue biopsy, are you going to do it or are you going to refer it to the surgeon? And make sure you explain to the patient what's going on. What is your lesion? What's happening? A patient with a smokeless tobacco lesion. Make sure you tell him if you continue to do this on this site, this may turn into cancer. So that's important. Next. And we can go through this. This is just kind of a comprehensive oral exam. Next. Make sure you check the tongue, make sure you examine the oropharynx. Biopsies Tissue biopsy still is the gold standard for diagnosis, so it's important to do that. And anytime you want to send a biopsy, I'm here available at UT. This is my email. This is my cell phone number. You can text me, you can write to me, you can email me, you can send me pictures. You can call me and tell me, I have a patient on the chair. I don't know what it is. Please help me. So I'll be happy to help you with that. Next. And just this, make sure you keep your eyes open. We like to know what the normal is. Every time there's an abnormality, it's good to recognize it. It's good to let your patient know, reassure them. Dentists are responsible for the detection of oral cancer. It can come back to chew you in the butt. If you don't diagnose it, a patient develops it, and you've seen that patient in the last 6 months, and you missed it, you may be liable. So make sure you keep your eyes open. When in doubt, call your friendly oral pathologist. And here I have some cases I brought in. I don't know if you guys want to participate. I don't know if we can spend 5 more minutes, if we still have time, if people want to go.
The session did end at 1, but if anybody would like to stay behind for 5 more minutes to go through the case.
If anybody wants to look at these cases, I mean, we won't do, but every time you have a lesion, this is just kind of an interesting thing. Every time you have a lesion on the gum, there's always 4 differential diagnoses for that lesion on the gum. There's we call it the 3 P's and the S. And the 3 P's are pyogenic granuloma, which we talked about today. There's another one called the peripheral ossifying fibroma. That's a lesion that looks like a fibroma, but it only occurs on the gingiva. And with that one also goes a peripheral giant cell granuloma that will only occur on the gingiva. And then your other differential is a fibroma. So pyogenic granuloma, peripheral ossifying fibroma, peripheral giant cell granuloma, and fibroma. And in this case, this one was a pyogenic granuloma. Next. Then this is an interesting case. So we have this lesion on a 78-year-old male with dementia who presents to the oral surgeon with this lesion on the lateral border of the tongue. When patients have dementia, obviously, we don't know how long it's been there. It's difficult to ask, it's difficult to get information, but we can look at this case, right? So what if I tell you that this patient used to be a smoker in his younger years, right? Is that gonna change a little bit? Maybe. Where's the location? It's lateral border of the tongue. So yes, it makes us concerned about it, right? What does it look like? Well, there may be some kind of striated lesions here, but it's also ulcerated and it's kind of red and this white, and it goes down here and there's some white down here and there's some white here. So what are we gonna do? Definitely do a biopsy, and maybe do a couple of biopsies. Maybe take a biopsy from here, but maybe also take a biopsy from here. Next. So yeah, that's very good. So sure, we took the biopsy and it turned out that it was mild to moderate dysplasia. And you can see here that these are called reedy ridges, and reedy ridges are usually kind of thin, but this one is kind of big and fat and kind of bulbous. And it's got some mitoses here, and there is some keratin formation up here. And this almost looks like a keratin pearl. So this is not acting very friendly. And then we find that he also has some candidiasis. So this patient had mild to moderate dysplasia with candidiasis on top. So we did end up suggesting for the patient to get all of that lesion removed, and he was treated with antifungal therapy. Next. This is another lesion on the floor of the mouth, and you see here, this is a pigmented lesion. And the patient really hasn't noticed if it had changed or not. But what do we have here? Right? This is a kind of a blue-black lesion. What should you do with this lesion? What should we do? Yeah, maybe it's a nevus. Yeah, it's in the differential. What else? A nevus or what else? What's another pigmented lesion? Okay, well, let's find out next. Next slide. This was actually an amalgam tattoo. And you can see that amalgam tattoo, this is what you see. It's this granular material, kind of black granular material, which is the silver in the amalgam, will stain the elastic fibers of the connective tissue. And so you see these squiggly elastic fibers stained with that silver in the amalgam. So this is an amalgam tattoo. Next. And then we have this case. Are you concerned about this case? This was a patient who had an extraction, and a month later, the extraction site had not healed, and then he was treated with antibiotics. And then after like a week of antibiotics, it healed a little bit, but after a month, he had stopped taking the antibiotics, this came back. And so this was squamous cell carcinoma. Next. And it was pretty awful. It was a younger patient. He already had a lymph node when he showed up to the surgery clinic. And this is a patient with a dome-shaped mass of the lower lip. She says it's asymptomatic. Sometimes she bites in it. She's had it for about a month. And what is the most likely diagnosis? Well, what do you think it feels like when palpated? Is it kind of firm or is it fluctuant? Probably fluctuant. And it probably won't go away by itself. It is a mucocele, so it needs to come out, and when you remove it, it needs to be removed with the adjacent salivary gland tissue. Next. I think we're done. Yeah, and so this is just the biopsy of the mucocele. Here's your surface mucosa, and then you have that big balloon of accumulation of saliva. This band around it is actually inflammatory cells that kind of try to wall off that mucus, and all around it are the accessory minor salivary glands that need to come out. Okay, I think that's it. Yep. Any questions? Any comments? Anybody?
Thank you so much, Dr.
I'm sorry I went
Robledo.
over 5 minutes.
Thank you.
Hello, this is Dr. Murphy. Can you hear me?
Yes, Dr. Murphy, nice to hear you.
Well, nice to see you today. And I want to thank Magda and Rosalie and their support staff for the program. And to thank you particularly for this presentation that you gave us here today, because it's very helpful, and it's day-to-day information that we can use.
Yeah, and like I said before, I'll go ahead and make prescriptions available, like a cheat sheet for the prescriptions, which is always nice to have when you kind of that under your treatment options, right? That you can
How do we obtain that? How do we get that cheat sheet?
So I think they're going to make the
Yes. So we will, yes, so
lecture
we will make-
available, and so when they make that available, they'll also make that prescription cheat
It'll
sheet
be on the
available.
Dent Echo website, Dr. Murphy, where we'll post
Okay.
this presentation as well as that handout.
And Carly,
Oh,
could you
okay,
drop-
thank you very much.
And
I
we
just wanted
will
to add
drop-
one other thing. We've seen an increasing number of lingual or tongue, what I'd call traumatic ulcerations. And usually, they have different characters to them, and we pretty certain what they are. But the common question is this cancer? Should I worry about this as it comes up? You can see the characteristics of the lesion. However, not to minimize their concern, how long would you watch this?
No
Just-
more than 2 weeks.
Dos
No more
semanas.
than 2 weeks. Yeah, you need to be very strict about that. If in 2 weeks that lesion didn't heal, it's gonna even help it to heal when you do that biopsy. Yeah.
Well, thank you very much.
Thank you so much, Dr. Robledo, and everybody for your participation. And all the resources, slides, will be available in on the website. And Carly, thank you for dropping the link in the chat. And also please complete the post-session survey. Link is in the chat as well. And we hope to see you next year on January 19th for our next DENT Echo session. Thank you, everybody.